Okay, let us leave it for discussion now, dear colleagues. Once again, our main task today is not to stop for our symposium to be dynamic and not to have long pauses. As we're working online in real time, we have certain problems. At the moment, the patient is getting ready for surgery. I will change the program not to keep you waiting, and we shall start the discussion, the roundtable discussion, and when we have a signal that our patient is ready, we shall make a very short, just translation from the surgery. And the only thing that we should do now, probably let's listen to the patient's case. He was prepared for planned gastrectomy, but we had certain symptoms which were detected in MRI, and in screening EUS, there was there were certain symptoms that alarmed us, and that is why we asked we asked for additional diagnostics, because the ducts should not be dilated for no reason. At the moment, probably we'll find a solution to these questions. What is dilatation is related to, and it will probably change the treatment choice, because if the patient has isolated gastric cancer, if it is locally advanced, then it's one treatment. Then if there is invasion into the pancreatic head, that should be either we should change the surgical treatment then. So I will say a couple of words about the patient. This is male, 68 years of age, gastric cancer, ulcerous infiltrative form with the extension to the stomach, posterior wall, from the cavity to the wall, or to the angle, and it's low differentiated or poorly differentiated cancer on histology. Additional EUS was performed in order to stage the disease, and in parallel they also assessed pancreatic and biliary zone, where the CBD was detected. We detected the expansion of CBD to 12.5 millimeters and PT up to 7 millimeters throughout. I would like to say it once again that we need to once again assess the pancreas and biliary area and understand whether it is related to the stomach disorder or it is a parallel diagnosis. Can you speak a little bit about EUS staging? So my colleagues did it, and unfortunately this slide doesn't, or this presentation doesn't show the stomach itself, but we are talking about the lesion of the whole stomach wall with the intrusion into the serous membrane. I looked through the images myself, and I have my own impression. I have seen the slices where it was clear that the tumor grew into the pancreas. It's my preliminary opinion. It cannot be final, of course, but I cannot exclude the fact that these processes are interrelated. So we are talking about invasive invasion of stomach cancer into the pancreas, exactly where they merge to the CBD and the pancreatic duct. Any questions to Dmitry? Can you put up the lights, please? Thank you. No questions. Thank you very much, Dmitry Viktorovich. And now, we do not have any answers to these questions by MS-CT with three-phase bolus contrasting, and we are expecting answers after EUS performance today. Can we get connected to the operating room? So, can you show the ultrasound, please?
Послушать комментарии относительно тех находок.
And we're ready to listen to the comments regarding those findings. Michael, yes, esteemed colleagues, we're great to hear at the final translation from the operating theater. Alberto learned the Russian already, Zolsky trying to hide it. Now I'd like to ask to show video, to start with the video to show the stomach tumor, and then we'll switch to ultrasound. Please, could we please switch to video imaging? So we here can see the mass in the stomach located in its proximal part. It has some ulcerations, and you see that the pylorus is open. And why should we do that? It's clear we should do that because it shows that we can move with endoscope to all the parts of this GI parts. And we discussed with Alberto we should switch to ultrasound so we can demonstrate those capacities of ultrasound we have in our hands.
Alberto, you can already see the tumors here. So this is the air in the ulceration. Да, и Альберт сейчас показывает.
So Alberto is showing thickened tumor, the tumor thickened by the tumor, and he shows ulceration place, which we can see because there are some air bubbles. Then we'll move the endoscope to visualize the liver. That's cava, vena cava, inferior. And that's a place of confluence with liver veins, or hepatic veins.
И вот мы исследуем сейчас.
And now we are looking at the parenchyma. It looks to be like in a parenchyma there is a lymph node, and now again the endoscope works in a scanning mode from the esophageal lumen. We can see structures, cardiac structures.
Mitral valve, сердце, left ventricle,
ventricle. Now rotating the endoscope, we can see an aortic valve.
Легочная вена, под ней располагается восходящий отдел аорты.
Under there is ascending aorta.
Трахея, которая дает акустическую тень. И далее мы...
Which gives us acoustic shadow. Then we rotate the device counterclockwise, and it's an aortopulmonary window, so-called. And here we can see
This one? Yes, this one. Вот. И здесь вот мы видим...
And here we can see a small lymph node, which is an inflammatory type, because it has no signs of malignization. Then we'll move endoscope into the oral direction, and we can see those arteries coming from aorta, brachiocephalic trunk. And then we... that's a place to scan the second group of lymph nodes. Everything is clean here.
We are looking at mediastinum to exclude lymph nodes, which are always which can meet with gastric cancer.
And if you find lymph nodes, what does it change?
If there is no any lymph nodes in the abdominal cavity, and we can meet with some lymph nodes in mediastinum, we perform EUS-FNA, confirm malignancy, and this patient is not candidate for curative surgery.
Yes.
So
there are very nice paper from Denmark, where they pick up 240 patients that are board of surgeons said that they were operable, and they did EUS. They found multiple lesions. They did 80 FNAs, and 15% were positive. So for or mediastinal or some liver lesion. So in 15% of the patients, EUS FNA changed the management. So this is what we were talking about before. So in this case, you save the patient from an unnecessary surgery, unless there's another reason to do surgery, and the cost of surgery too.
Поэтому даже вот если
And that is why, while we're talking about the CT scan, which is done by the, if you do mediastinal CT to exclude lymph nodes, this position where we look at this aortic pulmonary window, it's not always available, and it's not always provided with information on presence of lymph nodes.
Nodes in IP window.
Yes.
И эндоскопическая ультрассонография является, наверное, одним из золотых.
Ultrasonography uses one of the methods to assess this window. It's very important for patients with lung cancer, and for stomach cancer it's necessary.
1, 2, 3,
на границе.
We're at the border.
Границе желудка, на границе брюшной и грудной клетки мы увидели
We're at the border of abdominal and thoracic cavities. They do not look like benign. They look dark. We're trending to confluence. They're homogeneous, and this lymph node, as Alberto says, is an ideal for FNA.
Neoadjuvant chemotherapy, it's better than do surgery directly.
Вот сейчас мы демонстрируем стенку желудка.
Now we're showing this stomach wall. That's a stomach tumor which invades all stomach layer. That's thickness of the wall is about 15 millimeters, and we visualize aorta with select trunk, and then we look at pancreas. We see the select trunk coming out, then we go forward and we look at the pancreas. And as to the probe shows a little bit dilated pancreatic duct, and then we turn the probe and we move from the body to the tail. Pancreatic duct is about yeah, it looks normal. And
Parent channel.
I think it's normal. It's a little bit, there's a hyperechoic, it's a little bit fatty pancreas.
Да, как вот выглядит она по типу жирового липоматоза.
it looks like fatty lipomatosis.
Селезен.
With his splenic hilum.
So I think, so this is a T3, T4, because we cannot really see if it's subserosa or serosa with lymph nodes. So I think it's at least N2 by the number of lymph nodes we have seen.
И с учетом, да,
And then there was a questioning about the
many questions about the
main duct, no?
Of the parenchyma of the.
Okay, so I would go to the duodenum.
Вот, далее мы проводим эндоскоп.
Now we're going to the duodenum with endoscope.
Конечно.
Mike, one short comment. You should call in some words. We are doing pre-op staging of the stomach cancer. That's what we're used to. So you're doing it in quite a modest way. So when we see the patient, when we examine him and do the surgery, we we stage patients using TNM based on the pathomorphological methods. But today we're saying that modern methods enables us to do TNM staging before the surgery, which determines the patient management. As you can see, this patient is recommended not with the surgery as a treatment of choice, but with a neoadjuvant chemotherapy. And again, if you don't find any additional data showing that surgery is required, and now endoscope is in duodenum. Alberto shows here.
Is the pancreatic duct, the main pancreatic duct that measure 5 millimeters, so it's not normal.
Далее мы вращаем эндоскоп по часовой.
Now we're rotating clockwise to the large papilla.
So this is the bile duct, and this is the pancreatic duct.
И
Probably. Here. So this is the one under the cursor is always the bile duct, and this is the pancreatic duct at the level of the papilla. That measure 7.7 millimeters. So it's a dilated duct, and the dilation is segmental because it's in the head of the pancreas, while in the body and tail is normal. So
normal, yes.
This may indicate that this is a main duct IPMN, and we know that IPMN is it's associated with extrapancreatic diseases, malignancy, and one of the most frequent are GI tract. So colon cancer is the most frequent, and then also gastric cancer is very frequently associated with the IPMN.
And as you can see on the screen, we have a very good image. Мы снизу видим.
From below, we see
the main pancreatic duct. So follow down. No, follow more. Here. So this is the papilla.
Yes.
So if you follow down, you kind of separate. So this is probably a side branch dilated. So it's a main duct disease with also probably some side branch dilatation. So this is a side branch dilatation.
Yes. And what do you think about this? Is it nodule or?
No, there's no. I don't see any nodule inside. Sometimes you see small digital things. So in this case, because this guy might undergo surgery after chemotherapy, or depending on the protocol you have, this is something that should be really explore if he has main duct IPMN, because it might be. What do you want to? I think these are artifacts. So I don't see nodules inside that are.
Maybe this one is cyst and cyst.
Yeah, but it's just a movement. It's just tangential. So I don't see any nodules or any papilla inside the duct that may be. But I think what is very important in this case is the fact that then it comes back to normal size. Yeah. Because, for example, you can have chronic pancreatitis or papillary stenosis.
The dilation through the whole.
Yes. Because if the dilation starts at one point and there is a block, all the duct should be dilated. So when you find a segmental dilatation of the duct, it's more worrisome and more suggestive of a main duct IPMN. So I think there is a duct pathology, and this is a side branch dilatation.
Please show side branch.
Yes.
This is the main pancreatic duct.
Main pancreatic duct.
And
Follow.
And here is the side branch.
And
yes.
this is the side branch. Okay?
Maybe two side branch.
Yeah,
The
there are
first
maybe
one.
two.
First and
second.
This is the second.
Yes. And here also you see this side branch is also, you should not see normally. So I think this is a mixed IPMN with the main duct and side branches and side branches.
And what should we do next? First of all, we have a
This is a debating things what to do in terms of diagnosis because this is becomes a presumptive diagnosis. So if the patient is symptomatic, for example, if he has a pancreatitis, I think in this case you should do a sphincterotomy, a pancreatic sphincterotomy, collect the juice and see if there is mucus, or we can take a look also of the papilla endoscopically and see if there is mucus coming out. That this is not so frequent, but you know, if you have a mucus coming out from the papilla, you have a diagnosis of IPMN.
And if we take into account the prognosis of the gastric gastric cancer, stage 4, indeed.
Yes, probably I would not touch the pancreas for now. Or you have to discuss with the patient because at the end, in this case, you should have, you should do at least a Whipple. So, and you're gonna do total gastrectomy with a Whipple when maybe his cancer is gonna not be cured. I think in this case, for example, the fact that you give neoadjuvant chemotherapy, it's also good for see if he responds to therapy, because if he does not respond, it's a reason even more not to do a Whipple.
Ну, коллеги, у нас все-таки вопрос был по...
Esteemed colleagues, we had a question about pancreas, so maybe you have some questions, because it's a very interesting situation, because the whole day we discuss the need for examination for status of such patient. Maybe you have some questions from the audience from a point of view of the further management. Actually, you know, you responded to the most important question, because we don't see secondary lesions in pancreas, and metastatic lesion is not the reason for hypertension in pancreatic duct, and it should be concomitant pathology. Is it correct to say? Yes, you're right.
Diagnosis, first of all, gastric cancer, and then the IPMN, I think branch type.
Both. I think it's mixed type.
Mixed type. Yes, and the prognosis of the gastric cancer is more
worrisome.
Yes, worrisome, and the of course the IPMN is not the cause of the hypertension. Hypertension. No. Yes, there is no hypertension, and the gastric cancer is not the cause of some difficulties in the head of the pancreas.
You know what? We can also look around the liver if there's any fluid. That in gastric cancer, if you find small pocket of ascites, is the most important predicted factors of metastasis in the omentum. So it becomes really a metastatic disease. So it's kind of an end of discussion about what to do with the pancreas. And there are some small cysts. I think torque a little bit here, maybe. That maybe so it's a multifocal cystic disease. We can look around the liver.
И сейчас мы
Now we moved with endoscope to the stomach.
Higher up, away from the away from from the lesion. Look how big is this one. So this is probably N3.
Yes. И мы сейчас...
So now again we're coming back to the liver. We'll try to
осмотреть вот это.
We'll try to look at the liver. That's the left lobe. We're rotating the endoscope.
Liver.
Да, сейчас мы видим стеатозис. Maybe frequent.
With your steatosis.
Frequency. Let me take out this one. Frequency here. It's more than this. There's. Okay.
Вот мы смотрим левую долю печени.
Now we're looking at the left lobe of the liver. There is no signs of ascites.
Where the liver finishes, so it makes like a triangle.
И здесь у нас нет признаков никакого.
It doesn't look that he has.
There's no signs of anything.
He has ascites. So I don't know. He has done a CT in.
I don't know. Ну, в общем-то, следующую задачу, которая...
So in the next task, we said you did all the objectives, you fulfilled all the objectives. We got complete information, excessive information about the patients. The only thing we can do is to do a stage in laparoscopy prior to neoadjuvant.
In this case, if you want to do stage laparoscopies to find out if he only has metastasis in the omentum, because you already have a T4 and 3 disease, so this is probably a guy who needs chemotherapy and maybe radiation also, because otherwise he's going to bleed. And then maybe you can do staging laparoscopy after the therapy. In this case, the laparoscopy, I don't think it changed. I think the laparoscopy staging, there's a paper from Sloan Kettering that showed that if you have a not advanced stage on EUS, it may be worth it to do the laparoscopic staging, because sometimes you find more advanced disease. But in this case, where you have advanced disease, it's probably not going to change that much what you're gonna do, because you're going to give anyway chemotherapy, and then you might reassess after he has finished chemoradiation therapy for the need to go surgery or not.
Thank you very much. Everything clear, and I absolutely agree with you. Thank you very much.
Вот, ну, поэтому мы заканчиваем. Спасибо большое за...
That's why I finish up, and thank you for your most interesting questions. Thanks a lot.